We've known for the last 10 years at least reasonably well how to prevent mother-to-child transmission of HIV, but we are worried that insufficient progress is being made in this region, which contains most of the countries in the world with very high rates of HIV infection. So this meeting here, we've called together the senior technical representative of the 9 countries in Eastern and Southern Africa. We've also brought together basically all of the key partner organizations who are working with countries to support actions. Other UN agencies, to really just put our heads together to sit with our colleagues from government collegially and say what is it that we should be doing that maybe we're not doing enough of to help accelerate activity. So we're also reviewing the status of paediatric treatment of HIV. Are children getting diagnosed early enough? Are they getting the right drugs? Are the drugs available? Are we monitoring programs? Are we monitoring programs and are we seeing success? The trial in Uganda, which got us all thinking, my goodness, you know, there is a drug regimen, a relatively low-cost drug regimen, which can slash the risks. One of the people behind that trial was Dr. Philipha Musoke.
Since 1998, we had the AZT story, and since 1999, we had the Velephi story. We have evidence from resource-limited settings that we can reduce mother-to-child transmission. So I highlighted today all the different research that has moved on since single-dose nevirapine. We've recognized that it is an effective intervention in reducing mother-to-child transmission, but it's not the most effective intervention. Other clinical trials have been done, and in Africa, showing that if you give antiretroviral therapy during pregnancy, like AZT, in the last trimester of pregnancy, and continue it for a week after delivery, the combination of AZT and the single-dose nevirapine I talked about earlier reduces mother-to-child transmission even further. However, despite the recommendations by WHO and the national policies in country, we failed to scale up those more effective interventions.
Are you making steady enough progress that you're going to meet the goal? Or are you, in a way, daring to say, you know, maybe the goal will slip by a year or two?
We are building systems as we are scaling up our PMTCT and pediatric HIV as well. We are on track to meet our target for 80% by end of 2010. And it's just that for us, we've been making progress quite steadily over the years.
We have made rapid progress, and we are almost there as far as achieving that target is concerned. In PMTCT, the national coverage is almost 80%. So really, we are almost there. Now, in the areas where we are concentrated, the counseling and testing, for example, uptake in most of the facilities is 90% and above. Where we are still working very hard to go above the 80% is in the ARV prophylaxis. We are almost there. In pediatrics, however, we have not made as much progress.
Describe why you feel you're not on track, or if you are on track, what could be done? You know, what would be the one or maybe two things that you feel could happen in your country?
In Swaziland, I think we have not yet infiltrated well into the community, community advocacy is not quite good, especially for PMTCT. And now zeroing down to the male involvement in the issues of access to health services, especially HIV services. In Swaziland, the women are still relying on the males for permission to go to the hospital, even to take their medication.
In Kenya, if there was one magic thing I would do that would make a difference in this country, would be to avail staff for the various health facilities in the country. Staff shortage is almost crippling us in this country. Our government stopped employing staff a good while back, and we have lots and lots of interventions that we are introducing against very, very few staff who are just not capable to stretch too much. For example, pediatrics needs so much attention and confidence on the part of the healthcare worker. We need to train people, we need to mentor them on site, we need to literally handhold them through the process of treating children because many people are scared.
Ugandan strategy was more interested in reaching, the measure was up to health center 3, but clearly now we are seeing that more than 50% of our mothers actually attend and go for services at the lower health level, health center 2. When these days, these statistics, can we be helped as managers to interpret these proportions, to translate these proportions into absolute numbers? Because for us as we implement, we can work on absolute numbers. How many pregnant women that are positive might be in this district or in the catchment area of this health facility, so that when I make those absolute numbers and figures, then I can see where thrust should be.
My appeal to partners is to assist us at 2 levels. That's at the community level and at the facility level. With the community level, we would like help with our 3-day postnatal care, using community health workers. How do we integrate that 3-day postnatal care into the work that community health workers are already doing? You know, to ensure that the baby is getting the AZT and mom is actually adhering to her feeding choice. At the facility level, we actually need to strengthen our referral systems for women with low CD4 counts and who are eligible for heart.
Malawi, of course, there are a lot of issues, but I think it will center around on the infant dose of ARV prophylaxis, and this mainly I would suggest if some of the investment is going to the community, because, like for example, in our country, the institutional delivery is still around 54%, so a lot of moms are delivering at home, and then some of them who might be HIV positive are missing their infant dose.
Mozambique Human Resources Development Plan for the health sector is now there, but it needs to be resourced in the next years, because one of the issues is not only that the facility doesn't have enough resources, but that they are not overall enough help.
Is the private sector and are NGOs and FBOs sufficiently involved? Are they getting the support they require? And is government taking it the right role or the right balance between stewardship, setting guidelines, standards, measurement, in helping others to take some of the burden? Anybody want to sort of comment on that particular question?
Women are getting better attention from the public than the private. A lot of privates have not quite embraced PMTCT. They are not really testing women as a routine and giving the services as required, even testing children. So private sector is a little behind.
For Africa, the common meeting ground is through the South African National AIDS Council, what is known as SANAC, and it's actually chaired by the Deputy President of the country. SANAC does not make the policies, but is a very strong advisory body. And it operates through sectors who all make representations. The FBOs, the disability sector, we have the children's sector, women's sector, business also sits on in SANAC. And then as the Department of Health, we coordinate the different partners and try and map out where they are and try and coordinate their areas of expertise.
What we've heard so far has all been really, really good stuff, good advice, good guidelines. But I guess I'm thinking, what are the real priorities? What are the real sort of asks that we could come out with, proposals? We don't want to be daydreamers, but I think we need to dream a little. What could we do in the next 3, 4, 5 or 6 months? What ideas? Quickly to the panel, and then we'll open it up. Yeah.
I think that if we could get the ministers of health somehow developing a report card on their functions and what they do, how effective they are. And I'm not sure if this already exists in some of the countries now, but in terms of really holding them accountable, so it's very public.
One priority, I think, for the Clinton Foundation in the year coming, it would be to publicize some of the work that we've done around loss to follow-up and pediatric retention, because I think drawing attention to the huge numbers of children that are lost to care in the system is something that really needs significant attention.
Loss to follow-up. What are we going to do about loss to follow-up? We're not going to hire thousands of new doctors to go around chasing up people, so we have to use community capacity, the mothers-to-mothers kind of approach or similar approaches to get out and do that loss to follow-up.
For 3 to 6 month changes, I think this is real on-the-ground stuff, and you've got to come up with things that are going to make a difference there. Doubling the number of kids on ARVs. Stop talking about rates, talk about numbers. People don't understand rates. If you got 10 kids on ARVs last month, get 20 kids on ARVs this month. If you got 10 mothers in treatment last month, put 20 mothers on treatment next month. Immediate, measurable things that people on the local level can appreciate, and give them prizes. Come up with awards that motivate people locally and put the resources in place to make it happen.
Thanks, Peter.
To me, it's really at the service point level, what should they be doing? Should be very clear, but matched with supporting budget and government commitment to targets on what they need to do.
I've got 3 people from the floor I'm going to ask to give a very quick opinion, or maybe to challenge the panel, or both, but very fast. Mark Sterling.
For 2010, there's 3 things that need to be done which really build upon existing commitments and the discussion which we've been having the last couple of days, and also the ITPC report. One has got to be that move to scale. Scale is important. Even if there's challenges of quality, scale is absolutely important, and to hold leaderships and systems and partners accountable to that 80% target is absolutely key and cannot be lost and cannot be diluted. Secondly, what we've learned is that there's problems with just scale without concern about efficiency, and that's that target which somebody said around halving loss to follow-up. That's something which can be quantified and could be constructed at national to local level as a tangible target. And then I think the third one, which Mitch is referring to, is doubling between now and the end of 2010 the numbers of kids who require treatment actually accessing and benefiting from it. 3 very concrete targets, but linked with trying to push the process of coverage into a human impact.
Thanks.